it's my distinct pleasure and actually to pay homage to some of the references that Dr. Barrelay made. Mariah, Dr. Schnobrich and I are sitting in the LeBlanc Reproduction Center here at the Rood and Riddle Equine Hospital. And of course, she's greatly missed. But it's very nice that seminal work that she did, as well as the legacy she left here at Rood and Riddle, continue. So we're very happy for that.
And of course, Emma, she was a great friend of Peter Rossdale's. And Peter Rossdale, who was a wonderful man who all knew him, sadly passed away a few weeks ago. And he's a great loss to us all. But he was a wonderful man, and he and Michelle got on like a house on fire.
I can imagine, and you're absolutely right. I don't think anybody who is an equine veterinarian does not know the name Peter Rossdale, whether they have an interest in neonates, in reproduction, we still quote the study that he did with regard to the wastage in racehorses, yes. That seminal study with lameness from many years ago. So a massive legacy that extraordinary mind left us all, wonderful thought process. So thank you very much for reminding us of that. And we are sad that he's no longer with us. And so without further ado, we are very fortunate to be joined by Mariah Schnobrich, who is a vibrant and wonderful member of the community that we have here and globally. Dr. Schnobrich is a Penn graduate, has many other talents, including art and murals and all kinds of crazy things, which her podcast will tell you about. If you go to Rood and Riddle Stallside, that's a very amusing podcast, oh Dr. Schnobrich.
We had to cut a lot out, so what you heard was about a third.
Yes, well, the bloopers got cut out, but anyway, Dr. Schnobrich is a specialist in reproduction. She's a board certified diplomat of the American College of Theriogenology, and she's now going to give us the United States perspective on the same knotty problem that Dr. Barrelay was tackling. Dr. Schnobrich, I'll give you your computer back to share your screen.
Great, thank you, Emma, and thank you, Dr. Barrelay. That was, when Emma asked me to do this, when Dr. Adams asked me to do this, I thought it was, again, just an opportunity to hopefully, let me share my screen. To sort of, she maybe had heard something from the farms about my inappropriate use, and it was my opportunity to learn from that and make a confession to the group. So I found it really interesting to hear your comments and your use, such as Ceftiofur intrauterine. That's something that a lot of farms, I think, routinely do. And there's a lot of similarities, but it also strikes me too that there's, it's not, right. There's a lot of differences as well. And somehow they're still getting the same pregnancy rate, which leads me to wonder how relevant what we're doing really makes a difference. So anyway, as a theriogenologist, anyone who's practicing reproduction, sometimes I think we feel like we have a huge impact, and maybe some of the comparing results from your practice and ours may lead us to believe, I'm not sure exactly on some of these things, how much effect we're really having. So anyway, this is my disclosure slide. There's a nice aerial view of flying out of Lexington. Beautiful place to work, as is Rossdale's, as we've seen. So basically the overview that I was gonna go through in this talk is, what do we know about antimicrobial resistance in equine reproduction? And Dr. Barrelay has given us a very nice intro on the World Health Organization and One Health background, which I think is really helpful, and hopefully I won't have to go into as much detail, so I appreciate that. And then what are the current practices in the United States? How are we using antibiotics? What dictates our use of it? And then specifically in practice, what are we doing? Post-mating induced endometritis and use of antibiotics, how can we improve the efficacy of our treatments? A lot of this will cover some of, that review by Dr. LeBlanc is very timely and comes back to us on this topic. And then I was going to briefly touch on intrauterine versus systemic antibiotics and antibiotic use in pregnancy in the pregnant mare, and a brief overview on the stallion and considerations for how we're using antimicrobials. So does antimicrobial resistance affect us? Absolutely. As previously discussed, it has a huge impact. The recent edition of The Lancet there was an article that stated that unequivocally this data is showing that reducing veterinary antimicrobial use leads to a decrease in antimicrobial resistance in animals, again, meaning that if the vet is using the antimicrobials responsibly, we can affect resistance. And also that the veterinary antimicrobial use is not operating in an isolated setting, but affects the occurrence of antimicrobial resistance in humans. There's no question about this. So what are the concerns? There's plenty of review articles, research articles that demonstrate that antimicrobial resistance is occurring in equine pathogens, some that are for different diseases, and some that have zoonotic concern. I know that I've heard of cases of MRSA infections in stud farms and the concern that that's being passed to the mares. This is real, and it's happening now. And then also we have evidence that the antimicrobial resistance of uterine pathogens is changing over time. Again, the previous discussion from Rossdale certainly shows that. And here in this study from 2013, this is the percentage of E. coli isolates that are resistant to these antimicrobial drugs. And you can see that for ampicillin, it's going from 42 to 61% in 2008. And some of these are, from 50 to 69% in our sulfas. So there's variable changes, and certainly there's also probably regional effects. So when we think about what are our guidelines for how we are using antimicrobials, we certainly don't have as much in place as they do in Europe. And I think we are sort of in the age, and it's probably a window that's closing because there's going to be more pressure on us. But at this time, we have a lot more freedom, especially in equine practice, because it's not a food animal, and the direct implications on public health, I think people are just starting to realize. So as United States veterinarians, we have the governing body is the Food and Drug Administration, which goes through a stringent approval process for animal used medications. And prior to 1995, the majority of veterinary drugs were used in an off-label manner, meaning that the FDA had not approved them specifically for equine use, bovine. And so a lot of the drugs were used off-label. And at 1994, 1995, the FDA passed the AMDUCA Act, or Animal Medicinal Drug Use Clarification Act. And the idea of this, in talking to some of the people that were involved in it, was that the language was hopefully vague enough that it allowed veterinarians the ability to prescribe what they felt was appropriate, but also limited, particularly more in food animal, some of the medications that were going to have a public health impact. And what AMDUCA says is that if the FDA has an approved product labeled for that use, that is what you are supposed to use. So you might think that there's 5 different medications for inducing ovulation, but if there's an approved product, you're supposed to use that product. And that off-label use, or not for what that medication is labeled for, is approved, is your ability to use that product at the veterinarian's discretion. And you must have, excuse me, a veterinary client-patient relationship. So for example, if you are the overseeing veterinarian on a farm and they have SMZs, if you've never seen that horse and they're using a prescription that you've authorized filling, technically we could be in trouble for that. And I think that's a situation that a lot of us can relate to. Also that you should be using an approved product first, and that the use of animal and human drugs is permitted in non-food producing animal practice, such as equine practice, except when the public health is threatened. And as you can see at Rossdale's, they've already limited some of the medications that are going to have implication for human health. So the other set of guidelines that applies to us is what was drafted by the AEP and given to the AVMA. Thank you. Emma's bringing me water. I must look thirsty. So these guidelines, they're very dense, but I think it is informative to go through them. What I highlighted were things that kind of made me go, as a repro practitioner. And Antimicrobials should only be used within a valid VCPR. Again, this brings up the question from someone from the audience about what do you do when people are stockpiling medication on a farm? That's not good, because if those antimicrobials, whatever medication they have, they shouldn't be administered without you seeing the patient. And we know that that's an issue. Obviously, we need to be educated about microbial use. Culture and sensitivity should be performed when the identity of the organism or antibiotic sensitivity pattern is unknown. I think we can all relate to uterine infusions used in post-breeding and some of the issues with the time-sensitive nature of if we diagnose endometritis and the delay on culture and sensitivity results. So this is a real problem, and maybe it should make us think that antimicrobial use in this situation may not be appropriate. Selecting antimicrobials that are appropriate for the target organism and administered at a dosage and route that are likely to achieve effective concentrations. One of the issues, again, in reproduction is that a lot of the times we may not know exactly what that target organism is, and the dosage and route of, especially in intrauterine administration, there isn't a lot of research on some of these medications and the duration that it remains in the endometrium. So are we really doing the best job when we're pouring antibiotics in and we don't exactly know what we're treating and we don't exactly know what the tissue levels are? Also using antimicrobials with the narrowest spectrum of activity and known efficacy in vivo or in vitro against the pathogen causing the disease. Certainly, I've been taught and have been witnessed in practice more of an approach of using a broad spectrum agent because you don't necessarily know what you're treating. And so a lot of times these are prophylactic treatments. And what's really interesting is that when we hear our colleagues in Europe talking about it, prophylactic treatment is not okay. It's not appropriate use of antibiotics. So this is interesting and is hopefully makes us all think about this. Again, select antimicrobials of lesser importance for humans, avoid using combination antimicrobial therapy unless there's evidence for either an increase in efficacy or suppression of resistance development for the target organism. There's a lot of antibiotics that people use intrauterine in combination, whether it's penicillin and gentamicin. Some of these have evidence in the literature that they should not be used and actually inactivate each other. So do we, I think we have to balance our clinical impressions versus what's in the literature. And this obviously would ask us to look at this a little bit more closely and maybe more responsibly. Again, I'm certainly guilty of some of these things, but I think it's important for us as a group to try to think about it. When appropriate and feasible, use local therapy over systemic therapy. I think we can talk about this. I have a slide on this, but this is also when we're faced with certain uterine infections, maybe we should always be doing default local therapy before systemic. Sometimes there's, cases that may not be appropriate, but we need to make sure that we're not causing resistance. And obviously systemic therapy has some higher ramifications for that. And then also consider the use of effective and practical non-antimicrobial treatment alternatives. This is exciting because in Repro, there are a ton of topics on this. So I'm gonna skim through this part of the talk because I feel that the previous speaker did an excellent job on going over this. But this is the data of what we're doing in the United States here. So this was a survey that was conducted on KVMA veterinarians. And it basically asked, what are the antibiotic prescription practices that we use here in Kentucky? So 92.5% said they could prescribe antimicrobials without supervision. About 50% believe that they did indeed overprescribe antimicrobials. I'd put myself in that category. And 93% agreed improper use contributed to the selection of antimicrobial resistance. 20% thought that there was improper antimicrobial prescription practices among their colleagues. And 15% thought that there had been an increase. So basically we don't have great policies in place. We're overprescribing them. were contributing to antimicrobial resistance right here in Kentucky is kind of what I take away from this. And I would say I'm guilty of this as well. So another survey, which was of AAP members and ACT members, or American College of Theriogenologists, about 70% of these were US veterinarians. And in this study, this was done by John Descanio, it showed, not surprisingly, strep zoepidemicus, beta hemolytic strep, and E. coli were the two most commonly isolated bacteria of fungal isolates, Candida and Aspergillus. Pre-breeding antibiotics, so before the mare is bred, was used in problem breeders, mares with excessive uterine edema, awaiting culture results, and the owner's request. Post-breeding antibiotics were utilized in cases of mares with a previous history of inflammation after breeding, excessive uterine fluid, mares bred late in the year, routine procedure, previous pregnancy loss, and actually one other thing that was mentioned was client pressure. So of those, honestly, if you pick those apart, not a single one of those is really a valid use of an antibiotic. You could argue. Excessive uterine fluid, there are certainly, if it's clear, there are some mares that have clearance issues. You don't necessarily know if it's infectious in nature. The most common, and this is a continuation of that study. So the most common antibiotic used for intrauterine treatment before receiving their culture antibiotic sensitivity results. So this is before, obviously, when you're empirically treating or you believe the mare has infectious endometritis, giving 20% with ceftiofur, about the same for gentamicin. Timentin or ticarcillin with clavulanic acid was 13%, ampicillin 12%, procaine penicillin 5%, and down the line. So you can see there's a broad range of things we're throwing at mares before we even know what is going on. How can we improve that? The other thing that's really interesting and comes up a lot is how long are we treating mares? What are the indications? So in this study, they showed that it went from anywhere from 1 day to a week, with 3 days being the most frequently, that was the window that people most frequently used intrauterine antibiotics. So I'm gonna highlight where I sort of struggle as a repro clinician that's competitive and I want to get my mares bred, and also my responsibility as a veterinarian. So the first is that often therapy has to be initiated without sensitivity results. So I have this little image of the uterus and endometrial edema and fluid. When we see this as the person who's responsible for managing the mare the day after breeding, this doesn't look good. And I think that a lot of us are trying to throw an arsenal at this that is going to hopefully result in a pregnancy 15 days later. So if you take a culture at that time, 3 days later, you are going to have your sensitivity. And at that time, it's too late to be lavaging because you're too close to the window of when you may be too close to the window of when the embryo is going to enter. So sometimes we do have to use empiric therapy. Question is, do we have to use antibiotics? The other thing is that in reproduction, we know that our diagnostic tests to test for infectious endometritis have severe limitations. So our sensitivity and specificity of swab culture and cytologies and even biopsies can miss what's there. Certainly great work by Dr. Ferris and others have shown that biofilms, as well as latent stages of the bacteria, may make it so that these traditional diagnostic methods don't even identify what's going on. And then also, the other challenge is that it is not ideal to administer intrauterine treatment when the mare isn't in estrus. So these are all concerns. So hopping over to the topic of what we do for post-mating induced endometritis, I wanted to look at, in Kentucky and in a lot of large breeding practices, post-breeding infusion is pretty routine. I think in some groups we're getting away from it, but what is the evidence? Where did this start? And I can see this must have been the Utricin that we were talking about in the previous discussion, but some of the early work by Pycock in 1996, he compared after breeding, no treatment, oxytocin, antibiotics with infused within 72 hours of breeding, or oxytocin with antibiotics. And what came out of this is that oxytocin alone was about as effective as just an antibiotic infusion. So if we're trying to be responsible, I think that's pretty significant. And this was 1,200 horses. Now, oxytocin with antibiotics had an even improved effect. So it's not to say that there's not some benefit, but I think this makes us question, how important is it to use antibiotics versus oxytocin when one might be more responsible? The other study by Pascoe, similar, antibiotic treatment infusion with procaine, penicillin, and neomycin increased the pregnancy rate slightly, or the conception rate is what they cited in the study. And the greatest was when they included antibiotics and plasma at a 74%. Again, there's not a huge increase with just antibiotics alone. So I think we're missing something when we think just throwing something in there, one infusion is going to do the trick. And again, this more recent study in 2002, and there are a lot of studies like this, but I like these because I felt like they showed that the ecbolic agents like oxytocin were about as effective as an intrauterine infusion. So in the 2002 study, no treatment. Now, what's interesting here in this study was these were problem mares, thoroughbred mares that had a history of post-mating induced endometritis, and they were also older. So we know that in older mares, they're more prone to inflammation. So if you gave these mares no treatment, you are not going to be kept on the next year as the farm vet with a 22.5% pregnancy rate, right? So that went up to 53% with a single antibiotic infusion with just oxytocin, not significantly different, just 52.5%. And when you combined antibiotics and oxytocin, it was better than either one alone. This is impressive to me. That's a big jump. So treatment is necessary, but we need to use the appropriate treatment. So just kind of brainstorming on the literature that's out there and giving us all options or things to think about in our arsenal. Let's talk about the things we can do to improve treatments around breeding that have evidence that they've been shown to help either with microbial load or improving pregnancy rates. So uterine lavage, there have been studies that show that pre-breeding uterine lavage, as well as post-breeding lavage, 4 to 6 hours after breeding increases pregnancy rates. This makes sense because we know that that inflammatory cytokine ramp up about 6 hours after breeding is happening. And so by removing those inflammatory stimuluses with lavage, we can have an effect. Now, it's interesting to me to hear that some people lavage with only 1 liter versus 500 mils versus 3 liters. And I can tell you in my practice, as I've gone to using more large volume lavages and lavaging the mare until she is clear, instead of just doing it to say I've swished and in and out, I've had a lot less mares with bacterial endometritis, and they seem to do a lot better. So Dr. Bradykamp actually was really instrumental in helping me learn that, and especially in mares with C-section scars or areas that just 1 liter is not going to dilate. So I really encourage you, part of the issue is certainly trying to get that bacteria out, but really removing it. Ecbolic agents, as we saw in those previous studies, are very helpful. Dr. LeBlanc did beautiful work demonstrating that 10 international units or half a cc in our US oxytocin IM every 4 to 6 hours causes a much better coordinated contraction of the uterus. And this can be used pre-breeding as well as post-breeding. And that was a better effect than oxytocin given IV or in higher doses because of the way the uterus has more of a synchronous contraction. Cloprostenol, really interestingly, will cause the mare's uterus to contract for longer, and given 4 to 6 hours after breeding, causes the same evacuation. There's also some evidence that cloprostenol given 4 to 6 hours after breeding may help with ovulation. So that is something that I really love to use. A recent study showed that dinoprost in lower doses, IM and estrus decreased inflammatory cells. So that's just, again, ecbolic agents are your friends, especially in those mares with pendulous uteruses. If it's sitting there in a swamp, and especially in our live cover situations in which the semen are going to have to swim through the swamp, we need to get that out before breeding. There's also good evidence with immune modulators. Then there's more research being done. Some of this is Buca's work from 2008, but there's some exciting work with Settle, which is Mycobacterium cell wall extract, showing that it's changing the inflammatory patterns of these resistant mares, or susceptible mares, or your problem mares that are going to have more inflammation. Dexamethasone given at the time of breeding is shown to also improve pregnancy results. And PRP, this is again kind of coming back from plasma, and this has been tossed around, but there's some new work showing not only Segabanazzi's work that demonstrated that you could see an increase in pregnancy rate by just a single administration, but there's some new work just this year showing that there's some antimicrobial effects of PRP itself, which is really great because that's a broad spectrum treatment that may be effective. The non-antimicrobial antibiotics that we can use, I love Povidone Iodine. We did a study here with Casey Cromer looking at our results from biofilm assays, and I was really surprised to see that the highest killing and biofilm disruption was achieved when using this low solution, this low percentage of Povidone Iodine. So that is something when you see that really nasty uterus the day after, I would feel very comfortable with a large volume lavage of that. And at the lower concentration, it does not have the same inflammatory response that may interfere with CL formation. So I think that's a good broad spectrum, and there's evidence that it's working at least locally in our area on a lot of our pathogens. Some of the work by Ryan Ferris has shown Tris EDTA, and specifically Tris EDTA disrupts biofilm and has some antibacterial properties, as well as Serogen, which basically sort of acts in a little bit of a similar way with a membrane disruptor. So if we are going to infuse an antibiotic or we feel that's necessary, ideally we'd love to have a culture and cytology. I put on here gram stain. There are some practices that routinely gram stain their culture and cytology prior to breeding. But if you come back with, if you request a gram stain, you can see if this is a gram negative or gram positive, and that may help you have a more narrower spectrum of antimicrobial that you use. Also, the morphology of the bacteria on the cytology may help. So normally cocci are going to be gram positive, and rods are usually gram negative, but the gram stain may help us be more specific about our use. And then again, removing the debris to increase efficacy. We know that aminoglycosides and certain antibiotics are inactivated by debris. So if you ultrasound a mare the day after breeding and she has echogenic fluid in her uterus, infusing an antimicrobial that's inactivated by debris is maybe not going to be the most effective. You may need to lavage prior to using that, or just lavage in general. And how am I doing on time? Okay. All right, so treatments of chronic endometritis. I just want to highlight, I have learned so much from many people in practice, from Dr. Riddle, Dr. LeBlanc, Dr. McLeod, who I know is on this call. It's not just about the bacteria that's in the uterus. And I put up these slides because it's so important as a repro vet that you look at these things before you even talk about treating an antimicrobial infection. So if the mare has severe Cushing's, you can treat that mare 5 different times and she's going to grow 5 different bugs. Until her immune system is under control, that's going to be a real problem. So a lot of times if I have a mare that has a systemic health issue, I don't even mess with the uterus in some of these bacterial infections until we get that under control. The anatomy, so persistent contamination. If she does not have an appropriate Caslix, or her vulvar conformation is so poor that she's contaminating her vestibule and vagina, you're going to continue to get mixed infections. Urine pooling, aspiration, all of these things need to be ruled out as a cause of contamination. And also looking at the anatomy in terms of the distribution of the intrauterine antibiotics. So in some mares, an infusion of 20 mils may be efficacious, but if the mare has a giant pendulous uterus and there's a foot separating the tip of the uterine horn from the body, you may need to think of other ways in order to reach all the affected areas. And then culture and sensitivity. As I said, I'm not going to go into this in too much depth, but we know that we have some limitations on the sensitivity and specificity of our diagnostic tests. these are more considerations. So we I mentioned that mare that has a really pendulous uterus and the uterine horns are up by her hip, and then the uterine body is down way below and she's sway backed. Is that a case where a systemic antibiotic may be more appropriate? I certainly have felt that way in the past. And so while we're guided to use intrauterine antibiotics, I think we need to ask, is there a biofilm in the left horn that we're not reaching? So lavage and biofilm disruptors may be appropriate in those cases. The duration of treatment, this is again, I mentioned in that survey, you can see we're all over the map on this. So the stage of cycle during treatment is important. Katrin Hinrichs demonstrated that if you treat a mare in diestrus, your likelihood of establishing a fungal infection is much higher. And we certainly know that the mare's immune system is more prepared to deal with contamination, uterine contractions are better, all of her abilities to evacuate the uterus and resolve inflammatory insults is improved during estrus. So we really need to be treating these mares when they are not under the influence of progesterone and during estrus. And I think any of us have known this from when we've seen mares that have been put on a progestogen and have contamination. A lot of those endometritis cases are really, really severe. Going back through the literature, it's interesting. There was a recommendation that the duration of treatment is based on severity. So mild cases are 3 days, moderate 5, and if it's severe, 7 days. I think some of us do this based on how lavages are improving, but just to kind of think about that, because we want to make sure that we have resolution of the infection, and it's important that it's adequately treated. Are we using bacteriostatic versus bactericidal, and what are the synergistic interactions? So when we get our sensitivity and we're selecting our antimicrobial, this is important. I mentioned uterine lavage and some of these agents, Dmso, vinegar, hydrogen peroxide, as well as biofilm disruptors that all of you guys are familiar with. And we touched on this in the previous topic, but what is the normal flora of the reproductive tract? And there's some evidence, and there's a lot more evidence that probiotics are really important. Oral probiotics are important because they may alter the immune system of the mare and also change the pH of the reproductive tract. And that may be part of why oral probiotics can be beneficial when we're trying to resolve chronic endometritis. Just for the sake of time, I put this slide up. These are a lot of our intrauterine antibiotics that we use. And I would say that commonly I hear people using here. So penicillin, gentamicin, amikacin, timentin, ceftiofur, polymyxin B. What I want to highlight is that each one of these has different spectrums of action. Depending on the literature, they can be considered bactericidal or static. But the other thing to think about is their mechanism of action time dependent or concentration dependent? And when you look at some of these, it's really interesting because ceftiofur, for example, is a time dependent antibiotic, but in the studies that looked at endometrial concentrations, it rapidly declines. So it's once it's in the uterus, and we think of an infusion, it was suggested that you would have to infuse that multiple times a day. I think clinically we feel that that's an antibiotic that works well, but these are just things that we should try to consider if we can. I have the dosages here. It's really important with our aminoglycosides to remember that they can be really irritating to the endometrium. And I've certainly seen mares where they have not been buffered appropriately, and they can cause some serious inflammation and sloughing of tissue, which we know isn't great because it can lead to fibrosis. There is a beautiful, Ryan Ferris's work on biofilm has been really helpful to all of us. And if you look on the Colorado State website and just search on Google for Ferris biofilm Colorado State, this chart comes up, and this shows us how to use biofilm disruptors with specific antibiotics that increases their efficacy. So the other thing that's important is just because it's good with one antibiotic doesn't mean that it's good with another. So for example, acetylcysteine can inactivate certain antibiotics when combined. So we want to make sure that we're knowledgeable about the arsenal that we're using. One of the things that I will make a comment on is the use of hydrogen peroxide and Dmso in the concentrations. I have seen some mares have really severe reactions to a 30% Dmso infusion, as well as to hydrogen peroxide. So I think you're always safer on using a more dilute formulation of these in our desire to do no harm. And I feel that I've seen more mares on hysteroscopy with scalding than people have seen before. And I wonder if it's due to our inappropriate use of some of these agents in combination. So I just caution you, but I think this is very helpful, especially in those chronic cases that we can't seem to resolve. And the other thing I'll mention about that is that there are biofilm assays available that you can test these agents in. So I know Haggard's has one, Riddle has one, where you can submit your isolate and we can test the efficacy of these biofilm disrupting agents against those, which is helpful in some of these cases. All right, and I am, at the rate I'm going, I'm gonna have to cut out the stallion.
Oh dear.
No, I'm just kidding. All right. So indications, indications for systemic antibiotics. So in the literature where it's been cited to use systemic antibiotics are for persistent chronic endometritis. I put this picture of the swayback mare up because I do feel that some of these mares, that's the only way to get tissue levels consistently, but it obviously comes with, we need to know that that is not how we're supposed to be using it. If we can do local treatment, that's better. So there are going to be cases where it may be indicated, but not in all cases. Placentitis, obviously you can't do intrauterine treatment, or you shouldn't, except in very, very, very rare cases. But placentitis is one where systemic antimicrobials are appropriate. Retained placenta and metritis, obviously getting all those tissue levels. It's much easier to do that with a systemic administration. The systemic administration results in a higher MIC with even distribution throughout the reproductive tract as compared to intrauterine therapy. That makes me personally, as the repro vet, want to do it for all of my cases, but I know that that's not necessarily right. It also may be appropriate when you're treating very chronic infections that are going to go on beyond estrus. So the mare's ovulated and now you're treating her in a window in which her cervix is closed and maybe her immune system is not as capable to handle intrauterine treatments. Or if she has a particularly friable uterus, it may be more appropriate, rather than putting an antibiotic that's inactivated by debris in the lumen, in a parenteral use or IV treatment or oral. The other thing is that the systemic therapy doesn't irritate the endometrium. We know medications like Bacterial or enrofloxacin in that formulation can be very irritating, whereas given IV do not have the same effect. So this is the antibiotics that have been tested for systemic use. And what I included in here was also from the literature, which antibiotics actually cross into the fetal membranes, because I think it's important to remember that there have been studies done in all of the antibiotics listed here, and some of them are appropriate for the pregnant mare and some of them are not. So at these dosages, these are the antibiotics: penicillin, gentamicin, ceftiofur, equisol, the sulfas. But this product in specifically, there have been studies done in the pregnant mare to demonstrate this: doxycycline in the oral form and enrofloxacin orally, as well as IV, can reach these levels. Ceftiofur, we need to know, is not an appropriate medication for the pregnant mare, so Exceed would not be an appropriate systemic choice for a placentitis. And when we talk about how we're using antibiotics in the pregnant mare, I think I'm going to be very honest. It is practice to use prophylactic antibiotics and progestogens. So there are a lot of mares that are on Regimate and 1 week a month are treated with SMZs, doxycycline, or some other antimicrobial. And the question is that we know from looking a little harder at our regulations that prophylactic use is not great. But when we have a history of a mare with pregnancy loss, particularly from ascending placentitis or poor cervix, or the farm manager is pressuring you, or it's an incredibly valuable mare and we know we've lost it before, it's tempting to institute these treatments. And I would say that anecdotally, I think there are people who feel that this makes a big difference. What do we know about placentitis treatment? The work, there's lots of studies, but basically that the combination of an antibiotic, anti-inflammatory, and a progestogen increase the outcome or the viability. There's another study that came out looking at the use of ECP in pregnant mares, and this is kind of interesting, but they found that the addition of ECP without Altrenagest actually increased the outcome, improved the outcome, the clinical outcome of an experimental induced placentitis model. So what do we do? How do we kind of make sense of this? One other thing that I want to say, talking about the prophylactic use, is there's also some evidence that it's not helpful. Dr. Fedorka presented a very nice with Dr. Ball and out of Gluck, looking at nocardiaform placentitis. And I was involved in looking at some of these mares, and I was really surprised to hear that the prophylactic administration of antibiotics did not decrease the risk of nocardia placentitis. And they said that 10.3% of the mares receiving prophylactic antibiotics in comparison to 3.6 of the control mares. So what this meant to me was that there are mares that we're giving prophylactic treatment to, and even though the sensitivity of nocardiaform placentitis demonstrated sensitivity to some of them and the antibiotics that we're using against it, it may not be the best treatment. This study, to me, there's a couple things that I could argue either way, but I think it just means that we need to look at it a little bit closer. And what I would propose is that sometimes the prophylactic treatment may treat it only a little, but if you do it for a week, it's going to come raging back. So how can we improve these results? I think increased screening is really important. Here's an image right here, just as a break from talk about antibiotics. This is a mare with nocardiaform placentitis. This is her endometrium, and this is that classic separation of the chorioallantois off the endometrium. So I did feel in looking at these mares that clinically treating them, in some of them you saw an improvement. So I don't think it's fair to say that antimicrobial use doesn't help nocardiaform placentitis, but I think we need to be better about it. So the ultrasound is very helpful. It's not perfect, just like our culture and cytology, but it's another tool. And I would really encourage people to start using it more frequently. They do it in humans, they do it in many other animals, and those late gestational screenings are important to recognize when you're starting to have an ascending placentitis or nocardiaform, as well as the transabdominal approach. How else can we identify there's a problem without just treating with antibiotics? So total progestogens and estrogens in mid to late gestation can be helpful. So identifying that there's low estrogens may show that the placenta or fetus, there's some issue there. And certainly in a mare that has vulvar discharge, I think it is, I used to be scared of putting a speculum in and getting a culture and sensitivity, but after working on a number of these cases, I think it's critical that you understand what you're looking at. And even a gram stain or looking at the cytology will help guide your treatment. Mammary development and mare history may also help us do a better job. So very quickly, antibiotic use in stallions. So we have some live cover concerns that have been touched on. If they culture something, what are the penile treatments that they're getting? Semen extenders certainly contain antibiotics for cooling and freezing, and these antibiotics can actually negatively impact the semen. And they don't eliminate the bacteria, but they reduce the load. So we need to think about how necessary are they? And there's also some new evidence that it may alter the reproductive flora. So there is debris and contamination in any semen sample that's collected. There's normal commensal organisms that are present, and what is truly a pathogen versus just an isolate from this commensal growth. I think we're still trying to figure it out. It's interesting to me that in Europe, they do have like Taylorella, and they have to be more careful about their culture results on some of these, but they certainly pay more attention to Klebsiella than I think sometimes we do in our sheds here. And yet, are the pregnancy results that different? I don't know. There's some literature that shows, and they didn't necessarily do capsule typing, that breeding to a stallion with a Klebsiella infection did not alter the pregnancy rate. So the bacteria that we worry about when we get them on a culture, obviously Taylorella in the US, we should definitely hope we don't find that. Klebsiella, E. coli, and Pseudomonas. And I've got, should I wrap that up? No, you're good. So one of the things, the question is, when you look out at horses in the wild, they get pregnant and obviously no one's washing their penis or culturing their penis. So a certain degree of contamination is going to happen. And that there have been studies that have looked in these sheds that wash the penises, and they can culture the mares and identify if there's transmission or what was the pregnancy rate. This study in 2014 showed that the live cover pathogenic bacteria found on the stallions' genitalia did not affect the occurrence and type of isolate found in the mare's uterus after breeding by live cover. So I think that's, basically there's going to be contamination, and most mares are going to be able to resolve that. It's probably more resistant mares that are an issue, but it is a good standard of care to be culturing stallion penises so that if we do have an issue, we can identify where it's coming from. It's interesting to know that about 10 to 30% will have a negative bacterial culture. And really the ones that we're concerned with are pure growth with too numerous to count colonies. And obviously neutrophils in the ejaculate are a concern because it may be an infection somewhere else in the reproductive tract, like the seminal vesicles. This is concerning in thoroughbreds as well as in cooled ship semen or frozen semen, because we know that the more bacteria are present, they will decrease semen quality. And we also know that the unnecessary treatments can disrupt the natural flora. So is there bacteria in semen? Absolutely. It's a little scary to see what these numbers are, but 66% of cooled ship semen samples have bacteria and 83.6% in frozen. So when you look through the literature, the number one thing that has been shown to help with reducing the bacterial load is hygiene. So good cleaning, environmental contamination, minimizing that. So when you have sand and dust that gets kicked up, that may not be ideal. Make sure your water source is good, that you're wrapping the breeding mount and not having multiple stallions jump it without having some sort of protective covering there. And then the semen extenders, particularly if you know that there's a stallion that may have a specific issue with one bacteria, you could tailor to him. And here's just evidence of the negative effects that these antibiotics have on sperm quality. INRA is probably our most commonly used semen extender in practice, and it seems to have little adverse effect on the sperm motility. So what can we do? Cleaning and supporting the normal bacteria flora, so only washing with water, not changing the pH of the stallion's penis. Using temperature decreased as in cooled and frozen semen certainly decreases the life cycle of the bacteria as they're dividing. There are other tricks like fractionating an ejaculate to isolate the sperm-rich fraction, which may decrease the bacterial load. And sometimes people are in live cover, they may be pre-infusing the mare with intrauterine antibiotics, or if they're doing it in cooled ship semen, treating the initial sample and then extending for freezing without antibiotics. Again, we're trying to implement these guidances in how we do it, and it's pretty clear that a lot of the things we do not follow what we're supposed to be doing. The other thing that's been mentioned, and they've used this, there's one study in stallions and some in boars, is the physical removal of bacteria either through centrifugation and filtration. It reduces the load, but again, doesn't cure it. So that's all I've got. Thank you everyone for your time. I really appreciate it.
That was a fantastic talk. Thank you so much indeed, Dr. Schnobrich. We're very, very fortunate to have so many excellent veterinarians in the Central Kentucky area. We're really spoiled for choice and obviously big clinics, and Dr. Schnobrich is here at one of them. Now, Dr. Schnobrich, you've got a couple of questions here. The first one is thanking you for a wonderful talk. but also to actually, if you could just explain a little bit more about the use of tris-EDTA and I think Serogen or
Serogen? Yep.
and how you would use them and what Serogen is, please.
Sure. Tris-EDTA chelates some of the ions that are important to forming the cell wall in the bacteria. So basically the thought is it came out of treatment for otitis externa in dogs and was used for a lot of mixed bacterial infections that happen in dogs' ears. So they would lavage it in, it breaks up the biofilm and also has bactericidal properties. So that was looked at in some of the biofilm studies by Dr. Ferris and has been used in conjunction with antibiotics because it seems to have a synergistic effect when combined with something like amikacin. So where I like to use tris-EDTA, and the other thing I should mention is Tricide and tris-EDTA are different. The tris compound itself is actually different, and you want to make sure that you're using the tris because it's actually more effective, and that's what they used in a lot of these biofilm studies. So you just have to ask if you're purchasing Tricide. Some things are labeled as Tricide and actually have tris in it. I know that the Root and Riddle product, that is the case, but also just check that because there is a difference in efficacy. But where I really like to use it is on my gram negatives. So if I culture an E. coli, my first treatment a lot of times will be a uterine lavage. And I will, if I'm waiting on the culture and sensitivity, I may infuse a 500 ml volume of Tricide. And then in my treatment going forward, it's a lavage with anywhere from 100 to 500 mils of Tricide and 2 grams of amikacin added to it. If that's the sensitivity, that would probably be what I would use. And I've had good success with that. And I like the larger volume of it. But that would hopefully, that would be where you would use that. Now the Serogen is interesting. It's a cationic protein. What I understand is that they basically identified it on reptile skin as an agent that had antimicrobial properties, broad spectrum. And it again, disrupts cell membrane. It also has some anti-inflammatory effects, which I have to admit, I don't quite understand all of. But the Serogen has been used as a post-breeding infusion or a lavage. In my hands, I have liked it on, let's say, a maiden mare that might have a little bit of fluid post-breeding, but doesn't look too bad, but I'm not 100% happy with her. And I might want something that is, I don't want to leave any antibiotics or a large fluid volume in her uterus because I'm afraid of uterine clearance issues with this mare. And that might be something nice that's a lavage. It may have some broad antimicrobial activity, but I'm not hopefully creating resistance. And it may also have some anti-inflammatory properties.
Excellent, thank you. And then somebody's just asking for clarification. It's on the first slide of your presentation, and it's regarding systemic antibiotics. And it was with regard to the prolonged effect of systemic antibiotics versus intrauterine antibiotics. And I wondered if you had could expand upon that one.
Prolonged effect.
I think maybe that's it. This is
prolonged treatment regardless of if and asterisk. So basically that was not that the systemic antibiotics are lasting longer.
I wonder if it was this one. If the person could clarify whether it was related to the systemic antibiotic administration results in higher MIC and even distribution throughout the reproductive tract with systemic drugs versus intrauterine therapy. Is that perhaps what the person was getting at? Hold on a second. Sure. Let me see if this person would like to answer this. Would this person like to answer the question, ask the question?
There's so many directions we could go on this.
Yeah.
So I just need to the prolonged treatment, regardless of if and estrus, was more that you could use systemic antibiotics for a longer treatment duration because it's not dependent on the mare being in estrus to have those antimicrobials.
Go ahead and share that.
Hey there.
Hey, Scott, how are you?
Hi there. I'm sorry to interrupt. About the third line on that first slide, maybe I misunderstood, but my impression was that you were saying that there was enhanced efficacy of systemic antibiotics versus intrauterine antibiotics.
I wouldn't, so the wording may have been slightly confusing, but that it would result throughout the tissue, like from the tip of the uterine horn throughout, yes, and throughout the entire reproductive tract, compared to just intrauterine therapy, that you get very high concentrations, and obviously it depends on the antibiotic. And you're certainly welcome to chime in, because Dr. Bailey has done amazing research on placentitis and other repro-related things. So that was what I intended by that slide. If you disagree with me, please share whatever you think.
Well, it wasn't that I disagreed. I just thought it was a really interesting thought, because from my understanding is everything that where they've done biopsies of the uterus subsequently, or taken blood samples subsequently, including the work that we did on penicillin, would suggest that the antibiotic is pretty well distributed after administered. And I know that that was the case for Ceftiofur and penicillin. And I wanted to say there was another one where they showed good distribution. But anyway, I wasn't so much countering it as just trying to understand the statement a little bit better.
Yep, and I think one of the things that's hard about it is that in certain mares that are studied, you don't probably have this mare as seen above, or mares that expel the fluid more rapidly. I think there's a large variability in the results. And when we looked at our enrofloxacin results, it was pretty impressive, the tissue concentrations and how different they were between mares. So it stands to reason in my mind that systemic antibiotics is going to have a more uniform distribution, assuming that the blood flow to those tissues is more uniform in some mares. I don't know.
Okay. Can I ask one more follow-up question to that? It's kind of a practice question.
Sure.
We oftentimes talk about the tissue distribution of antibiotics, but in your sort of clinical view, when you're thinking about treating a mare with endometritis, so active endometritis, are you primarily worried about the bacteria that are in the tissue, or are you primarily worried about the bacteria that are intraluminal? And do you feel like our lavage is good enough to get rid of those intraluminal bacteria?
So that's a really good question. And I think it is mare dependent. So certainly I think there are some mares that have very diffuse, deep-seated inflammation, like the work that was done on latent strep infections, that in my mind, you are going to need to treat those deeper embedded bacteria. A lot of times you don't know clinically. I mean, I would say you have the, unless I'm able to do a biopsy right before I'm making a treatment plan. But when I am able to look at the biopsy, it alters a lot of times how I would recommend treatment. And I may be wrong in this, but when I have a mare with a very sort of abnormal anatomy and deep-seated infection, I do use a systemic antibiotic, because I feel like I'm more able to control what concentration, especially for the time-dependent antibiotics and for longer treatment, than just an intrauterine. And I have seen mares where one part of the biopsy looks totally normal, and then an area near a plaque looks very angry. And so I think there's also issues there, because it may be that the systemic antibiotic isn't able to reach the plaque or some of those areas. So I think it is kind of case dependent in how you're using it. I think that a safe combination is using lavage with a biofilm disruptor, because in a lot of these cases, we don't know for sure what exactly is going on in the uterus. And I would prefer to use intrauterine antibiotics as my first approach, just trying not to give systemics. But in a lot of the chronic cases that come in as problem mares, you do see that deep-seated inflammation And it is certainly suspicious based on the distribution of inflammatory cells that there's stuff going on deep in the glands that I don't know that just intrauterine treatment is going to address, if that makes sense.
Fabulous. Yes, difficult questions. Let's see. I think we've actually stunned everybody into
Silence.
Yeah.
Scott, does that answer your question or no? I don't know if you want to add anything.
Yes, it does. Thank you very much. I think that is a really good way of looking at it, in kind of trying to parse out that you're treating systemically for a specific reason. I really like the way you thought about that.
Okay, great. Thanks. Well, that means a lot. You're very smart and I appreciate it.
Excellent. Well, as I said, I think that finishes up our questions, but Dr. Schnobrich, thank you very, very much for putting this presentation together. I know you've been, you're really getting busy now, so taking the time to put all these data together is absolutely fabulous. And looking at how many people have stayed on for the whole time, obviously.
I know you guys are champs.
Absolutely appreciate it, but thank you very much. Everybody, we will be sending out emails with your certificates that'll come through the mail tomorrow at 5 o'clock. Please look in your spam. We don't issue repeats, and believe me, keep a hold of those emails so that you've got them for your CE credit. We'll be having some more CE later on in the year, and we'll let you know about that. But thank you very much, Dr. Schnobrich.
Thank you, everyone. Have a
Alrighty,
great breeding
guys.
season.
Have a good evening. Take care, everybody.